Hello everyone. I hope I'm audible. I hope I'm audible. You can see the screen also. Please let me know in the chat box. Okay, great. So let us start with the good evening everyone. Let us start today with the INICET recalled questions for the subject of dental anatomy and dental histology, oral histology. Okay, so let me start with the first question here. Anybody in the chat box, please type it if I'm audible. Okay. Yeah. See, most of the questions for the subject of dental anatomy and oral histology are straightforward. Most, I mean to say, at least 50 to 60% of the questions are one-liners in the subject of dental anatomy and oral histology. Okay. So few questions are a bit tricky, but majority of the questions will be usually memory based. So if you, for example, if you remember the numbers, like for example, evidence of calcification, enamel completion. Okay, so such numbers are very important. So you should always remember certain numbers here. If you remember those numbers and some single liners, that is that covers almost 70 to 80% of the questions. Rest 20 to 30% of the questions will be a bit tricky. Okay, we have to know about those. Now let us start with the first question. It's like which are the statement which is true here. Time and developmental event are mentioned here. Tongue begins to develop at 4 weeks of intrauterine life. From a unilateral lingual swelling. So here basically 4 weeks of intrauterine life, tongue begins to develop, and that development occurs from unilateral lingual swelling of the first pharyngeal arch. So these are the two statements. First statement says that tongue development occurs around basically 4th week of intrauterine life, and it develops from what structure? From the unilateral lingual swelling. So if you see this, the first statement is correct. Yes, tongue development occurs at 4th week of intrauterine life. But does it occur from unilateral lingual swelling? No, it occurs from bilateral lingual swellings. There won't be one lingual swelling, there will be two lingual swellings. So first statement is correct. Second statement, the developmental event, is false here. So option C is correct, is the correct option here. So little I want to explain here that the tongue development, if you see, basically we know that tongue has got two parts broadly: anterior 2/3 of the tongue and posterior 1/3 of the tongue. Okay, tongue can be arbitrarily divided as anterior 2/3 and posterior 1/3. Anterior 2/3 of the tongue basically arises from first pharyngeal arch, first branchial arch. So the first branchial arch gives rise to the anterior 2/3 of the tongue. Okay, basically the first branchial arch, what it does is it will give rise to two lateral lingual swellings and one median swelling. So these two lateral swellings are nothing but your lingual swellings, and this median swelling is called as tuberculum impar. So what happens is, actually the two lateral lingual swellings will overcover the one median tuberculum swelling impar. So two lateral swellings will basically overgrow the one tuberculum impar, and that leads to the anterior two-third of the tongue. Okay, so basically the first pharyngeal arch ventral aspect will give rise to two lateral lingual swellings and one median tuberculum impar. The two lateral lingual swellings will cover over the tuberculum impar and finally leads to the anterior two-third of the tongue. How does the posterior one-third of the tongue form? Posterior one-third of the tongue basically forms from the other three pharyngeal arches. What are the other three pharyngeal arches? First arch, second arch, third arch and fourth arch. Second, third and fourth pharyngeal arches gives rise to the posterior one-third of the tongue. Okay, so actually there is a part called as copula. That copula arises from these second, third and fourth pharyngeal arches. That gives rise to posterior one-third of the tongue. Okay, let us move on to the second question. Function of dental sac in tooth development is. So we know that basically enamel organ is a main structure which arises from the dental lamina. Okay, dental lamina gives rise to the enamel organ. That enamel organ, if I take for example a structure shape like this, cap stage, here you have, this is a cap stage of tooth development. Basically what I've drawn here is a cap stage of tooth development. Below this cap, here we have dental papilla, DP, and all around this, everywhere, enamel organ and dental papilla, we have dental sac. So dental sac will cover the dental papilla and enamel organ. Dental sac will cover the dental papilla and enamel organ all together, right? So this dental sac, what is its main function? Its main function is that it will contain blood vessels. So it is rich in blood vessels. Lot of blood vessels are there here. It is highly vascular. So what happens if it is highly vascular? If it is highly vascular, it can provide nutrition. It can provide nutrition. It can provide the oxygen, nutrients required to what? To the very important cells here. What are the important cells here? The ameloblasts. The ameloblasts are the cells which require this oxygen, which require this nutrition. So this oxygen and nutrition to the ameloblasts comes from this dental sac. Okay, exactly, it not always comes from dental sac. Primarily, initially, till the hard tissue is formed, it comes from dental papilla. Once the hard tissue is formed, what is hard tissue? That means here the enamel and dentine are formed. Here enamel is formed, dentine is formed. So what happens? The blood supply can't come from dental papilla. Then the blood supply comes from dental sac, right? So basically what we have to remember is dental sac is responsible for the nutritional supply to the important cells here. What are the important cells here? The vital cells are the ameloblasts. Ameloblasts are the cells which result in the enamel formation. Okay, ameloblasts. These are the ameloblasts which come from basically inner enamel epithelium. The inner enamel epithelium will become ameloblasts, and finally ameloblasts will lay down the enamel. So that's the second question. That main function of the dental sac is to provide nutrition. Let us move to the third question. Most vascular and innervated part of TMJ. Most vascular and innervated part of TMJ. Temporomandibular joint has got different parts. All of us know, right? So among this, there is one particular tissue here called as retrodiscal tissue. The most important tissue here that we see here is called as retrodiscal tissue. Now this retrodiscal tissue, basically what it does is, this retrodiscal tissue is, where do you see this? After all, you see this basically connecting between the TMJ and capsule. This retrodiscal tissue is basically seen between the TMJ and the capsule. For example, we'll consider this as a TMJ proper, and this is a capsule. So retrodiscal tissue, what it does, it basically connects the TMJ to the capsule. So this is a capsule, this is a TMJ. So retrodiscal tissue connects the TMJ to the capsule. So this retrodiscal tissue basically is highly vascular, most vascular part. Okay, there is one peculiarity of this retrodiscal tissue. Whenever we open the mouth wide, like for example, when we open the mouth wide, okay, what happens is there will be pooling of the venous blood in this tissue. There will be pooling of the venous blood in this retrodiscal tissue. Okay. However, when we close the mouth, there will be outflow of the venous blood. So the retrodiscal tissue is the most vascular part of the TMJ, and it has got a role, or the venous blood gets accumulated, pooled during the opening of the mouth, and it basically the drains out, or it comes out once the mouth is closed. So we should remember that this is the most innervated and most vascular part of the temporomandibular joint. Okay. After eruption, let us move to the next question. After eruption, tooth structure lost by attrition is replaced by lengthening of the root. This occurs due to, what's the meaning of that? Due to masticatory forces. Once the tooth erupts into the oral cavity, there will be attrition. So what happens if there is attrition? The occlusal height reduces. So, but this occlusal height, if it reduces, how to compensate the occlusion then? How the tooth, the opposing teeth there will be proper occlusion for the proper health, oral health, dental health. So what happens is basically the apical part of the root, cementum, is deposited. So this cementum, what it makes is, it causes the basically the lengthening of the root, thereby maintaining the proper occlusion. So the question is here is this lengthening of the root occurs by what? Apical deposition of cementum, apical deposition of dentine, post emergence growth spurt, juvenile occlusal equilibrium. The correct answer here is that it occurs by apical deposition of the cementum. Apical deposition of the cementum. So here what we have to remember is that there are two questions that you have to remember. First question is, see, there is a deposition of the cementum in the apical part of the root. Thereby there will be lengthening of the root, which will help in maintaining the occlusal height. Now the two questions which we can expect here is, what kind of cementum is deposited? It is cellular or acellular? It is cellular cementum. So cellular cementum is deposited. And what do you call this as? We call this as adaptation. This function is known as adaptation. So we have to remember that what is adaptation? Adaptation is basically nothing but a function of the cementum wherein in the apical portion of the cementum, the cellular cementum is deposited, which causes lengthening of the roots, thereby maintaining the occlusal height. Okay, let us move on to the fifth question here. Meckel's cartilage starts developing at. Meckel's cartilage starts developing at. All of us know that the first arch cartilage is called as Meckel's cartilage. What is Meckel's cartilage? The first pharyngeal arch cartilage is called as Meckel's cartilage. This Meckel's cartilage, this is a memory based question, that it starts developing at 32 days. That is almost 1 month intrauterine life. In the mother's womb, in the intrauterine life, okay, around 32 days, that is 1 month, Meckel's cartilage starts developing. Please remember this, the word starts, that means it begins. By next 2 weeks, that is almost by 6 weeks, intrauterine life, IUL, intrauterine life. By 6 weeks of intrauterine life, what happens is this Meckel's cartilage becomes a rod shaped structure. So it is no more now just a small structure, it becomes a rod like. Here comes the question, two things that we should remember. What kind of cartilage it is? Basically, this is a hyaline cartilage. So again, it's an important, you should remember what kind of cartilage is this. Meckel's cartilage. It is a hyaline cartilage. Secondly, where it extends. Second question, where it extends from where to where? It extends from the otic capsule to the midline. So it extends from otic capsule to the midline. So that is its extension. Now, third question that we should remember about Meckel's cartilage. What is its role? Why it has occurred here? What is its role? Because this acts as a template for mandible formation. This acts as template for mandible formation. All of us know what is template. Template means a framework. Okay, let me elaborate this little more so that you will better understand. Suppose this is the Meckel's cartilage. What happens is there will be a membrane. I can't show that in the 3-dimensional. I have made it the red color here. There will be a membrane around the Meckel's cartilage. In this membrane, what happens is ossification takes place. So this ossification spreads in all directions and results in mandible formation. So basically, what this Meckel's cartilage is going to do, it is just going to act as a template. There will be a membrane around this template. In this membrane, ossification takes place and that results in the mandible formation. That is why we should remember, how does mandible form? Mandible forms by intramembranous ossification. Mainly ossification is of two types, endochondral and intramembranous. Mandible mainly develops by intramembranous ossification. It develops mainly by intramembranous ossification. So where is that membrane? That membrane is present basically around the Meckel's cartilage. So directly Meckel's cartilage doesn't result in mandible formation. Please remember, that is why it just acts as a template. This is one of the important tricky question. Meckel's cartilage directly results in the formation of mandible. Is this statement true? No, it is false. Because Meckel's cartilage is just going to act as a template, framework. Okay, and there will be a membrane around this. In this membrane, there will be ossification. Ossification takes place. That results in finally formation of the mandible. Let us move to the sixth question. Periodontal ligament is a sensitive structure. Which of the following are primarily responsible for sensing pressure changes in the PDL? Myelinated nerve fibers entering PDL, C fibers via pulp, free nerve endings, large myelinated sensory nerve fibers. To attempt this question, let me explain two types of nerve fibers are there in the PDL. So in the PDL, we have basically two types of fibers. One which are large and myelinated, and one which are small unmyelinated. When we see in terms of numbers, when we talk large and small, we have to be very specific here. Large means 5 to 15 microns. Small, when I say, I mean to say 0.5 microns. So these large myelinated nerve fibers are mainly responsible for sensing pressure. So pressure sensation is mainly because of this large myelinated nerve fibers, sensory fibers, which arise from the alveolar bone. So alveolar bone will send some large myelinated sensory nerve fibers. Those fibers are responsible for pressure sensation. Whereas these small unmyelinated are basically responsible for pain sensation. Pain in the periodontal ligament is mainly because of these small unmyelinated nerve fibers. Okay, so this is the point. So now if you understand periodontal ligament, what will be the correct answer? Pressure is mainly because of large myelinated nerve fibers. Okay, so these are some minute things you should remember. Simple single liners. What is the size and what each fiber will carry, what kind of sensation. Okay, all those things you should remember. Okay, let us move to the next question. Keyhole pattern in the enamel is due to. Keyhole pattern in the enamel is due to. We know that keyhole pattern is basically electron microscopic structure of the enamel rod. Okay, enamel rod. So this enamel rod, if we draw this, for example, this is an ameloblast. This is an ameloblast. Okay, hexagonal structure that I'm going to draw right now is an ameloblast. This ameloblast, it is a schematic representation of ameloblast. If you can see here, the keyhole structure of enamel rod is the enamel basically, rod has got basically two parts, head and the tail. Okay, so this much part is the head part and this part is the tail part. So this pattern is called as keyhole pattern. So let me label this. This is an ameloblast, hexagonal structure, and this keyhole structure that you see here is basically the enamel rod. Enamel rod. So you can see here that this keyhole pattern is basically because of the ameloblasts. The ameloblasts are responsible for this enamel rod. Okay, so here the question is as a Stone's process. In the question, the correct answer is Stone's process. Why? Because Stone's process is nothing but extension of the ameloblast. So if this is an ameloblast, that ameloblast will give rise to one extension. That extension, this extension is called as basically the Stone's process. Okay, usually the students tend to get confused. What is Stone's process? What is Stone's fibers? Stone's process is extension of the ameloblast or process of the ameloblast. What is a Stone's fiber? Stone's fiber is a odontoblastic process. Stone's fiber is basically a odontoblastic process. So keyhole pattern is mainly due to the Stone's process. That is nothing but the ameloblast. So here one concept important you have to remember, that one enamel rod is formed by how many ameloblasts? It is formed by basically 4 ameloblasts. So one enamel rod is formed by 4 ameloblasts. And one ameloblast, it results or participates in the formation of how many rods? 4 rods. So this relationship you should know. So one rod is formed by 4 ameloblasts and one ameloblast will result in how many rod formation? 4 rod formation. Okay, let us move to the 8th question. True about calcification of dental hard tissues. Calcification, that means dental hard tissues, enamel, dentine, cementum, how it calcifies. There are 4 statements here. Out of this, the first and the 4th statement are correct. That calcification occurs by secretory roles of the cells. That means secretory, what do you mean by secretory roles of cells? There will be secretory cells, ameloblasts, odontoblasts, cementoblasts. These cells have got a very important role in the calcification. Okay, and Very important organelle required for that is lysosomes. Lysosomes are the cells which help in maintaining this calcified tissue. So dental hard tissues, always remember that it form important organelle here is lysosomes, not mitochondria. Mitochondria has got no role. So 1 and 4 are correct. So the correct option will be here, the option A. It has got nothing to do with the mitochondria. So option C is ruled out. As mitochondria has no role, hence obviously energy is not required. Enamel or any dental hard tissue calcification does not require energy. Okay, that is why option second and third can be ruled out. So only first statement and fourth statement are correct. That is why we can go with the option A. That is, calcification occurs by secretory role of cells and lysosomes are the important organelle. Please remember this lysosomes, role of lysosomes. In dental hard tissue, role of lysosomes is very important. First evidence of calcification of primary teeth in intrauterine life is seen at, see, that's what I've told you initially. For single liners, remember the numbers. Primary teeth, first evidence of calcification is usually 3 to 4 months intrauterine life. Intrauterine life, that first evidence of calcification takes place. First evidence, intrauterine life, 3rd to 4th month. So approximately if you see 3rd to 4th month, that comes to 13 to 16 weeks. So sometimes they'll ask you in terms of weeks, sometimes they'll ask you in terms of months. So you should remember any one so that you can correlate that. So usually 3rd to 4th month of intrauterine life, mother's womb, first evidence of calcification of primary teeth is C. Total time taken by an individual permanent tooth to develop is approximately. So this question is a bit tricky. You have to understand this. What do you mean by total time taken? Total time taken, I mean to say here is first evidence of calcification. First evidence of calcification, enamel formation, eruption, and root completion. These are the 4 things you should remember. Any tooth, there are 4 important stages. First evidence of calcification, enamel formation, eruption, and root completion. Approximately any permanent tooth, let you take any permanent tooth, this takes around 10 years average. Average, it takes 10 years. That means first evidence of calcification till root completion. Permanent tooth, first evidence of calcification till root completion. This entire things take, total time is 10 years. Okay, that's the median. Range will be 8 to 12 years. Okay, you take, I'll just take an example for your better understanding. I'll just take an example. First evidence of calcification of permanent central incisor. Let us take an example of permanent central incisor. So this around 3rd to 4th month after the birth, this takes place, and this root completion is completed by around 10 years. So we got it. So almost it's less than 1 year, and by 10 years there will be root completion. So almost it takes median of 10 years, range of 8 to 12 years for the permanent tooth. So this is just an example. You take any tooth, check first evidence of calcification and root completion. Average of permanent tooth will be 10 years only. True statement about, next question, true statement about Oddland bodies. First of all, what are these Oddland bodies? These Oddland bodies are nothing but, these Oddland bodies are also known as keratinosomes. These are also known as keratinosomes. These are very important structures. Where are they present? They are present in a keratinized epithelium also and non-keratinized epithelium also. You can see them in both keratinized and non-keratinized epithelium. These Oddland bodies, where are they seen? Which layer of the epithelium they are seen? Basically, we know that keratinized epithelium has got 4 layers: stratum basale, spinosum, grandosum, and corneum. So these Oddland bodies, they appear in the upper layers of the stratum spinosum, and they increase in number in stratum granulosum. So they are present basically in two layers, stratum spinosum and stratum granulosum. So the correct statement here is they are present in the upper layers of the stratum spinosum and stratum granulosum, keratinosomes or Oddland bodies. They can be seen in both keratinized epithelium and non-keratinized epithelium. True statement, they are not related to keratinization. Okay, that's a false statement. Release alkaline phosphatase. No, they don't release alkaline phosphatase. The Oddland bodies are basically made up of, they are also known as membrane coating granules. Sorry, I forgot to tell you. They are also known as membrane coating granules. Their basic, one of the important function of these Oddland bodies is they contain glycolipids. Glycolipids. What happens in the epithelium is these Oddland bodies will release their content in the intercellular space. Okay, the glycolipid from the Oddland body will enter into the intercellular space. Thereby, it forms as a permeability barrier. So, lipid is a barrier, right? So, the aqueous solvents, it acts as a barrier. So, very important function of Oddland bodies is it contains glycolipids basically, and these glycolipids will basically form a lipid permeability barrier against aqueous solvents. They are modified monocytes. No, there are nothing to do with the Oddland bodies with the monocytes. So obviously the correct answer will be the fourth option here, that they are present in the upper layer of stratum spinosum and stratum granulosum. Remember, okay. Just to add to the statement, Oddland bodies, they are present in keratinized epithelium also, KE, and they are also present in non-keratinized epithelium also. I have told you. But remember the difference in the structure. Remember the difference in the structure. In keratinized epithelium, they will be parallel elongated. They will be elongated like this with the parallel lamellae. Whereas in non-keratinized epithelium, they will be circular with the central amorphous. So basically, in keratinized and non-keratinized epithelium, what is the basic difference in the structure of the Oddland bodies? In the keratinized epithelium, they are elongated with a parallel lamellae, whereas in non-keratinized epithelium, they will be smaller, circular with the central amorphous structure. Okay, so let us move on to the next question here. In which of the following teeth, crown is wider lingually than buccally? Crown is wider lingually than buccally. So there are M1 is nothing but the molar one. Okay, maxillary molar 1, mandibular molar 2, mandibular molar 2, maxillary molar 1 and maxillary molar 2. So here maxillary molar 1 is the one correct answer, where remember, always remember this, the first maxillary molar is a tooth where it is wider mesiodistally, more on the lingual aspect rather than buccal aspect. So the lingual surface is wider, lingual aspect is wider mesiodistally compared to the buccal aspect. So in which tooth? In the maxillary first molar. Okay, there's nothing to explain in this, just a simple memory based question. We should remember about that. A temporomandibular joint, TMJ, starts developing at what age in utero? Basically, again there are developmental questions here. In utero, in the mother's womb, it develops around 10 weeks. Okay, 10 to 12 weeks of intrauterine life. Actually, it's a range is 10 to 12 weeks. So exactly what happens in this TMJ development is there are two blastemas. Blastema is condensation. There will be two blastemas here. One is called as condylar blastema. One is called as temporal blastema. This is a condylar blastema. This is called as a temporal blastema. So these two blastemas, basically, there will be a tissue in between the two. There will be tissue in between the two. So this tissue is nothing but will result in finally articular disc. So condylar blastema will result in condyle. Okay. Temporal blastema will give rise to glenoid fossa. The tissue in between will result in articular disc. So we have to remember that these condensations are called as blastemas. So all this formation TMJ begins around 10 to 12th week of intrauterine life. The exfoliated deciduous teeth serve as, we should remember that the primary teeth or the exfoliated primary teeth has got a very important role, that it is a major source for shed. What do you mean by shed? The stem cells. SHED. S stands for stem cells of human exfoliated deciduous teeth. So very important question, very commonly asked question. What is the major source for the stem cells from the deciduous teeth? So pulp from the deciduous teeth or the primary tooth is major source for stem cells. That is called as shed. Okay, this stem cells has got the capacity to differentiate specific cells. It is multipotent. Right? So all those are there. So it can give rise to odontoblast. It can give rise to it can result in the bone formation. It can result in the it can get differentiated into nerve cell. Okay, so shed is a very important term you should remember. Let us move to the 15th question. Which of the following statement is false about stem cells? So stem cells that you see, they can be activated without a signal. That itself is a false statement. We have already got the correct answer here, that it's a false statement. Stem cells require activation. Stem cells require activation. Stem cells have the ability of perpetual self-renewal. Yes, that is why they are called as stem cells. They have their self-renewal capacity. They have the ability to differentiate into specific cell types. That's what we have discussed just now. They can get converted into odontoblast. They can get converted into osteoblast. They can get converted into nerve cell. Stem cells have the potential for tissue regeneration and repair. That is what is used for. So tissue repair, regeneration, stem cells have got a very important role. So A option is wrong. It requires the activation or through a signal. Let us move to the 16th question. For permanent maxillary central incisor, ideal crown width to height ratio. Okay, this is more of a perio question. Prosto question. All of us know in the prosto there is something called as golden proportion. Golden proportion, right? So this golden proportion is usually 0.62. 0.62. That is the width to height ratio. If you take, it will be 0.62 or 62%. Okay, but remember, ideally, when you talk ideally, or they can say most aesthetically pleasing. Most aesthetically pleasing, then that ratio should be 0.8. So don't get confused. 0.8 is the correct answer here. Ideal crown width to height ratio in a maxillary central incisor is 0.8 or 82%. Okay. Let us move to the 17th question. Which of the following tooth shows least variation in the eruption timing among Indian population? That means among the Indian population, that means usually which erupts in a specific age is your mandibular central incisor. All of us know the first tooth that erupts in the baby's mouth is the mandibular central incisor. Usually erupts in the range of 5 to 7 months. Okay, 5 to 7 months. 6 months is average, 6 to 7 months, where the mandibular central incisor first erupts into the oral cavity. This shows the least variation. Okay, whereas all the other teeth, mandibular, second premolar, canine, first premolar, maxillary, all these will show a lot of variation. Okay, so simple question, you have to remember that least variation in the eruption timing. Let us move to the 18th question. True about afferent nerve fibers of pulp. Okay, afferent nerve fibers of pulp means the fibers which come to the pulp. Okay, afferent. Efferent means which go away from the pulp, which carry from the pulp to the pulp. What are they going to? What are they mainly? So the afferent fibers are mainly the sympathetic postganglionic. So pulp will receive nerves from sympathetic from cervical ganglion. So that cervical ganglion sympathetic fibers are called as postganglionic sympathetic fibers. Those post are going to supply blood supply to the pulp. So the blood supply mainly to the pulp is through postganglionic sympathetic fibers. Which is that ganglion? Cervical ganglion. So the correct answer here is sympathetic postganglionic fibers. Not true about cemento enamel junction. Okay, this is a straightforward question. We know that CEJ is of three types: overlap type, sharp type, and gap type. Okay, if you see this, dentine overlaps cementum. There is no role. CEJ, cemento enamel junction. What has got? There is no role of dentine only. So obviously the dentine overlapping cementum is not a type of cemento enamel junction. Most common type of cemento enamel junction is overlap type, where the cementum will overlap the enamel. The other type is gap, where there will be a gap between the cementum and enamel. The other type is where the cementum and enamel will meet at sharp junction. That is called as butt joint. Okay, overlap, gap, and butt joint. So there is no role of dentine here. Difference between deciduous and permanent dentition. So if you see, basically, this is a very important question. The main important difference between a deciduous and a permanent tooth is cervical ridge. What do you mean by cervical ridge? Let me draw this. Suppose this is the occlusal part. This bulge is called as cervical bulge or cervical ridge. This is very prominent in case of the deciduous teeth. Whereas permanent tooth, it will not be so prominent. It will be usually flat. Like for example, permanent tooth will be something like this. If I have to draw it, permanent tooth will be something like this. There won't be this bulge. The cervical bulge is not so prominent. Whereas this is a primary tooth. Whereas this is a permanent tooth. So cervical bulge, where it is prominent in the primary tooth. It is less prominent in the permanent tooth. More prominent in the primary tooth, less prominent in the permanent tooth. Okay, so this much is clear. What is the shape of superior surface of articular disc of temporomandibular joint? We know that superior surface of the articular disc of temporomandibular joint has got concavo-convex shape. Concavo-convex shape. Okay, so the temporomandibular TMJ has got a concavo-convex, articular disc has got concavo-convex shape. This is again a simple memory based question. There is nothing much to discuss here. What is the thickness of the prismless enamel? All of us know that there is a type of enamel called as aprismatic enamel. Aprismatic enamel. What do you mean by aprismatic enamel? The enamel which doesn't contain prisms. The enamel which doesn't contain prisms. This aprismatic enamel, usual thickness is 30 microns. This aprismatic enamel, usual thickness is 30 microns. 30 microns. And this aprismatic enamel is basically a surface structure of enamel. This is basically a surface structure of enamel. So there are different surface structures of enamel: perikymata, prismless enamel, enamel rod ends, right? So prismless enamel, which doesn't contain prisms, its thickness is usually 30 microns and it is one of the important surface structure of enamel. Let us move to the 23rd question. Which of the following are the principal cells of gingival epithelium? We know that gingival epithelium, that is nothing but the masticatory epithelium, has got mainly the keratinocytes. Because it's a keratinized epithelium. So where we know that gingiva is mainly the 75% parakeratinized. So main cells will be the keratinocytes. Lymphocytes, Langerhans cells, Merkel cells, that option A, B, C are nothing but your non-keratinocytes. All these three are non-keratinocytes. They are not the principal cells of gingival epithelium. Principal cells of gingival epithelium are keratinocytes. So that is what you have to remember, that what is a principal cell? The keratinocytes. Last question here. Periodontal fibers without an osseous attachment. Actually, this question is bit controversial. See here, the option given is transseptal, oblique, apical, interradicular. Strictly speaking, if you see this question, these three are only the true periodontal fibers: oblique, apical, interradicular. Transseptal is one which is basically a gingival fiber. It is basically a gingival group of fiber. It has got no osseous attachment. What I mean by osseous attachment, one end of these fibers are attached to the bone. Oblique fibers are attached to bone. Apical fibers are attached to bone. Interradicular fibers are attached to bone. Whereas the transseptal, which are the gingival group of fibers, basically, these have no osseous attachment or bone attachment. Okay. So that's about the questions of the DADH subject of the INICET pattern. I hope this session would have been helpful for all of you. Okay. So this is usually that's what I've told you. Most of the concentration in the dental anatomy and oral histology should be a single liner. Okay. Most of that will be a single liner questions and memory based questions where age, timing, dimensions, those are the typical standard questions that we can expect. Okay. Thank you very much and all the best for your next examinations.